back, everyone, to our third session of the day. This session is titled Personalized Medicine to Population Health, How Data and Analytics Drive Insights Across the Continuum of Care. I want to thank our sponsor, IBM, for supporting this session. You can check out information about IBM on the event website, as well as all of our other sponsors. Before we get started, a few quick housekeeping announcements. You can ask questions 3 ways while you're here. You can enter them into the chat box, which we encourage everyone to open the chat box because I'll be asking some fun questions along the way so we can get to know one another. So again, open up that chat box at the bottom of your screen. You can also raise your hand to action by clicking the raise hand button at the bottom of the screen. That'll let me know you have a question and we can call and you can ask questions live during the Q&A portion of the session towards the end of the program. And then the third way, of course, is to put it in the Q&A box that you see at the bottom of the screen. So you've got the Q&A box, you can raise your hand or you can drop your question in the attendee chat. With that, I'm going to turn it over to our 2 fantastic panelists. First up, we have Ekta. She is the leader of the Top 100 Hospitals program with IBM Watson Health. Welcome, Ekta. And then joining Ekta, Hagland, our editor, and leading the conversation with Ekta. So I'm going to turn my video and audio off, and I'll see you all for the Q&A. Take it away, Mark.
Thank you so much, Stephen. Thanks to everyone in our audience for returning for the session, and welcome, Ekta. It's a pleasure to have you.
Thank you so, Mark.
Absolutely. So I'm going to have you introduce yourself. I'm just going to say one sentence or two about what we'll be talking about, how we look at continuous performance improvement, how we measure performance and performance improvement, and kind of where this train is going. It's something that many in healthcare are very intently focused on, and Ekta Punwani is one of them. Ekta, why don't you tell us a little bit about, just tell us about your title, your role, and what you and your team are doing at IBM.
Perfect. Thanks so much, Mark. So a little bit of background. The 100 Top Hospitals program is almost 30 years old. And really the purpose of the program was to take hospital level data and produce a scorecard so that hospital leadership teams could actually not only look at their own performance, but benchmark across the country on how they were performing in the areas of quality, operations, patient experience, financials. These are things that as a leader, of an organization, you are continuously looking at. You're trying to balance your resources and priorities. So it's a really great way to have kind of a high level strategic benchmark. And so that's really, our program is really focused on giving folks that the set of tools, if you will, data analytics measures, so that they can better understand opportunities for improvement so that we can, as an industry, keep moving in the right direction.
Great, thank you. Well, let's kind of do a level set, Ekta, on where we're at industry-wide. So we all know that for decades now, we've been trying to measure quality outcomes and performance in hospitals, as well as medical groups and large hospital health systems.
Mm-hmm.
One of the many challenges has been there are like a zillion different measurement regimens out there.
Yeah.
I remember writing about this literally 25 years ago in California. And at that time, physician groups were very frustrated because they were dealing with literally 10 or more health plan based measurement regimens at the same time. It was just impossible to manage from the practice standpoint. So they got together and they created a unified system, which all the major health plans are involved with. Because physicians were finding it was impossible, like Aetna would have one set of measures and Blue Shield would have another. And what I think is interesting about this train, this conceptual train, is how things are starting to pull together and a certain number of measures are becoming consensus measures across the health system. And the way that we're starting to measure them is starting to become more consistent. And some of that is driven by exigencies from programs like MIPS, for example,
Mhm.
and on the hospital side, the readmissions reduction program, and HCAPs and things like that. Let's start at 40,000 feet. Where are we on this journey of 1,000 miles or whatever we want to call it, in terms of creating some kind of semi-consistent, broad measurement system for clinical performance for hospitals and medical groups?
Yeah. So Mark, really good question. And, I will say that from my perspective, I get to see it more from the hospital health system side. There is some consensus on I would say, on some of the measures that have been around for a long time, because we finally have gotten there. We've gotten some, risk adjusted inpatient mortality is something that everyone cares about. Patient experience is something what everybody cares about. But what I have found is that, just what you said, payers, employers, everyone is looking at sub pieces of the data sets that the hospitals and health systems have, and even from the medical groups. And so we keep looking at certain perspectives or certain patient populations. We still haven't figured out the set of critical measures. When we talk to, quality vice presidents, analytic teams, they are measuring thousands of different measures depending on the disease, so I still think we have a ways to go. But what I do think is really great than maybe 15 years ago is that everyone is on sort of the same course of, we need to measure performance in many different areas to know how to improve and to improve. I don't think we saw that from everyone, 15, 20 years ago.
Yeah.
There was a real lack in data, understanding, maturity, even how to use data to drive some of the decision making that they're doing.
Yeah. Let me ask you, great. Perfect. Perfect framing. So let's drill down in several different areas. First of all, are we getting a little closer to determining let's talk about hospitals, since that's your general area, what the key 10, 12, 15 measures are? Is a policy level and operational level consensus developing in that area?
I think so. I think if you start looking at, sort of the Venn diagram of all the different evaluations, so 100 top hospitals is one of them, of many. Payers, how hospitals evaluate themselves, what they present up to the board. When you start looking at that, I think there are a number of metrics that people feel really confident that we should be watching. And they align with the CMS value-based, guidelines. So I think that there is a lot of alignment there. I think that we finally got to that point, but now what we're evolving to is that a lot of the care is not happening in the hospital anymore.
Yeah.
So we're a little
just
bit,
when you're ready to measure it, it's not there.
Right. We are measuring it, but I think, I get tons of questions about, well, Ekta, when are we going to start to measure all this other care that's happening outside of our four walls? And we are starting to really look at those data sources. And unfortunately, I always struggle with, do we have the data that we need? Is it valid? Is it being captured appropriately? Is it being captured in the standard formats, et cetera?
Yeah.
So that's where we are, is that I think you're right. We have the consensus on certain, again, parts of the system, but when we think about outpatient care, all the other domains where we receive care, we have a little bit of ways to go, I think.
Yeah, absolutely. And to throw a further monkey wrench into all of this, we have been covering this phenomenon that is blossoming now, hospital at home.
Mm-hmm.
And how are we ever going to even measure that? Because, one of the standard things for hospitals is readmission, for example, people with congestive heart failure, diabetes, people who've had pneumonia, et cetera. Well, as you go into hospital at home programs, the definition of what an admission is changing, right? Like if you're admitted to the home, like it's fascinating. And all those programs are very different also.
Yeah.
Do you think let's drill down a little bit on the clinical side. From your experience, what are the several absolutely top measures, clinical measures, that you have found to be relatively reliable and consistent across measurement regimens?
Yeah, so I would say inpatient hospital side. I think that the ones that you'll see that are very accepted by most are, the 30-day mortality rates, the 30-day readmission rates, the inpatient mortality rates, because people know what those mean. I
Yeah.
think they're very easy to understand. So I definitely think those
And they're
are,
collected in a relatively standardized way, right?
yes,
That's the other, yeah.
yes, and we've been doing it for a while, so now people
Yeah.
really, understand.
They know what those are. Yeah.
Yeah, I think complication rates, that's another one. So we've got, I would say those are probably the big four, and then of course being able to drill down and looking at what you mentioned, the patient condition, our high risk patient population, et cetera. So, I mean, I definitely think those are the big ones. But again, there are, what percent of patients are being treated in the hospital in our US population, right? And so what are the other metrics that we should be looking at on the outpatient side? Or like what you said, in this new the new world of telemedicine, the new world of hospital at home, et cetera. So there's a lot more, but all of this, what I always think about is it's the perfect opportunity for us now to really get to the heart, and that is the data. How do we organize and digest and do something with all this data that's out there? It shouldn't matter what the setting is.
Yeah. Let me ask one really specific follow-up question, and then we'll continue. But would you agree that hospital-acquired infections are also a good standard one?
Yeah. From the patient safety side, hospital-acquired conditions, and we've got a number of patient safety events that are being captured.
Yeah.
So those to me are the PSI indicator. Those are so drilled into our minds and are being, followed every single day in many of our hospitals. So absolutely, yes.
Great. So what are the biggest challenges right now? I could list a whole range of possible challenges: data definitions, data hygiene, data integrity, even the way that organizations are collecting data. Those are some of the ones I can think of. What do you see from your perspective as the biggest practical, operational, and/or policy challenges?
Yeah, so I think I will probably highlight, if I had to pick, I would probably pick two. Data integration. So, because we are now in a place where we can't just have these silos of information. We've got public health data, we've got the CMS data, we've got payer data. I mean, there's just so many fragmentations in our system. So I think data integration is a huge challenge, and it's a huge opportunity for us. But the other one is probably something we don't, from a healthcare standpoint, always talk about, but but our CIOs will talk about it all the time, is security. When we think about what's happening to, even just last week, I think there were a couple of hospitals in the news, health systems that, had security issues. And so, we're not able to get into their charts, not able to provide care, et cetera. So security, I don't think we realize it, but healthcare is actually a huge, is very much at risk for data security. So, and I think that's something that's a blind spot for us, because we've got so much other data that we're trying to figure out and work through that. But those are the two things I would really focus on.
Okay, and I would say, it's so interesting because providers are being asked to share more data than ever, and yet we're also facing horrible, accelerating and intensifying data security vectors.
Yeah.
I wrote an article last week about several incidents that happened in France. Now, and interestingly enough, the French president, Emmanuel Macron, actually just committed 1 billion euros to a new program. What's interesting is most of the European nations are actually behind us in security. Even though they have nationalized systems, And that's perhaps why, because they've never thought about this. But these horrible, some of them appear to be coming from Russia, but wherever they're coming from, these data gangsters, as they're sometimes called, are now preying upon hospital systems
Mhm.
because they're easy to break into.
Yeah.
And so, yeah, so that's definitely an issue. Let me ask you another question. One of the things that I keep hearing people tell me, CIOs, etc., we need data scientists in hospital systems. We need them to help us figure out how to, I mean, for the future measures, all the things that we could be measuring that will be more refined, that will really, where you'll really be able to say, if we measure X, we can see that hospital system A is doing far better than hospital system B. And we can really zero in on meaningful data, but we lack some of the data scientists to be able to help us get there. Do you have any thoughts on staffing and things like that?
Mark, I'm glad you brought this up. So one of the things, and I will always, I've been working in hospitals and health systems for, over 20 years, mainly in the performance improvement quality space. And what I realized is that when we were focusing on improving, so whether you're improving clinical outcomes, operational outcomes, working with physicians and caregivers, at the end of the day, you need data to drive those improvements. That is our fundamental need when you are trying to change behavior, change, et cetera. So what I found really interesting in my work is that we spent so much time on the analytics, finding the data, cleaning the data, interpreting the data, sharing the information, that we didn't have a lot of time to spend on the change piece, which is actually where we want to spend our time, because that's really how we're going to make a change in our industry. So when we talk about analytics and data scientists, we need, and I will say that I've had the opportunity to meet with many organizations that are sort of far ahead in this game, and those that probably need a little bit of need extra support there. But we have a lot of data. We don't have the ability to take the value from that data.
That's exactly where I was going.
Yeah. And so it's, it's beyond the measures themselves. It's about, at the end of the day, we are in it to improve our patient care. So if we can't understand our patient scenario, if we can't understand where they are in their disease, care progression model, if we don't know who's at high risk, if we don't know some of that, it's really hard to make a change in the outcome. And so I think this new level of expertise, I'll say, of data scientists and analytics is going to be huge. It's going to be a really big deal.
I think so too, because it's often talked about in the performance improvement world, and I know you come out of that world, the virtuous cycle or blessed cycle of continuous improvement. You collect data, you analyze data, you find out what's really going on. Then you sit down with the clinicians and others who are involved and say, well, now we see that we're not doing so well on blah, blah, blah. Let's approach that and see what we can do. And then you devise interventions, and then you measure those interventions. And I think what we're going to need, all the measures that are kind of standardized are very important and will continue to be important. But I think we can get them very refined to where we're really figuring out down to the level of the individual clinician intervention. Are we making a difference? Is what we're doing improving quality? So I completely agree with you.
Yeah.
Let me ask you this. What have been the biggest learnings of the last couple of years, both in the program that you manage and how you see it nationally across the U.S. healthcare system?
So, from my narrow perspective of hospital and health systems, one of the things that I have been really learning about is that the hospital infrastructure, how leaders lead, how they make data decisions, how they analyze their information, is really critical in seeing good outcomes. The other thing I've been noticing is that we have now probably about 70, it's an estimate here, about 70% of our hospitals are part of a health system now.
Yeah.
And that's, that's very different than what it looked like 10 years ago.
Yeah.
And so what's changing about that is that health systems now not only are just growing, but they are looking for, how do we align our organization so that we have, and I don't want to use the word standard because I know people don't like that word, but how do we get alignment in our outcomes? And it shouldn't matter what facility or what hospital that we're in or which physician, did this or et cetera. How do we get that? And so to me, that's a lot about strategy and infrastructure and how we do that. So I'm learning more about where we're spending our time. And I think that is going to be the biggest area of opportunity, is that how do we look across the system so that we can, again, it's going to be data integration, right, at all those levels, across and down. And then how do we use the infrastructure we have to make change? And that's more complex than if you're in a single, hospital organization. So that dynamic has really changed a lot.
I agree with you. I think it's more complex. The advantage is these larger systems have more resources, both human and financial and operational. When we were all a bunch of community hospitals that were completely independent, the level of measurement that you and I are talking about just felt impossible on a certain level, like 6,150 bed community hospitals. It's very hard. Now, as you know, we have hospital systems that have 100 hospitals, 200 hospitals. The good news is those systems almost always have a chief quality officer. Some of them now have a chief data officer. And of course, they have a CIO and a CTO. Right. So there's some good things in that. What do you think? Oh, go ahead. You were going to say something.
No, I was just going to echo that. That's where I think the investment is going in. How do we, we've got hospitals and health systems now that are like in their second, third, fourth round of new EMR implementations because they know the value of the systems that they have. And so it's really now we're going to see a lot more of interest and interoperability. How do we really connect all these systems together? So I think there's going to be a long road to making that all work.
Yeah. And I think per EMRs, EHRs, hospital systems are only now really beginning to actually optimize their electronic records. They were so focused during the meaningful use era on just getting them going, right, and getting them working. What do you think will happen in the next 2 to 3 years nationwide?
So I think we have a couple areas. So I do think that the analytics domain, if you will, in healthcare is going to skyrocket. We have to have those capabilities and infrastructure, really built within our organizations if we want to change. And I think on the other side, we didn't really talk too much about this, but just some of the policies around reimbursement and some of that stuff will need to also adapt. Especially if we're looking to do more, telemedicine and treat patients beyond their hospital, their four walls, and really think about the patient in a longitudinal way. So how can we think about all the different aspects of our patients? How do we make it more personalized? Where do they live? Who's helping them at home? Lots of different sort of the social determinants of health, which we didn't really have a chance to talk about today,
right.
But I could talk about this forever, Mark, but there's so many.
I could too.
There's so many dimensions to this.
Yeah.
And so I think it starts with the data integration piece of it, the ability to analyze that information. And then our policies sort of need to come along with that so that we can, at the end of the day, support the communities we serve. That's what I get nervous about a little bit, because at the end of the day, all of this is very important, but still the number one challenge for our hospitals and health systems is cost. And so we've got to figure out how to do that.
Absolutely. So we have an audience question, which I'm going to ask, and then I'm going to leave us at least a minute or two at the very end so we can wrap up with closing comments. So this audience member asks, Processing health information is completely different from handling other types of data. What skills do you expect from a young aspirant to work with health data? Good question.
Really good question. So, I think what I have learned more about is it's not sort of the type of data, but what we're looking for is the skill set that when I think of a data scientist, is not just an analyst who can crunch the numbers and, figure out the statistic models, et cetera. But it's really how do we take in healthcare, especially because we have like more than 80% is not a definitive. It's usually comments, it's text, it's a lot of that type, images. I mean, there's a lot of other types of data information. So how do we organize that information? How do we use AI? How do we use machine learning? How do we use natural language processing? How do we use all that stuff? And it's really the strategy piece. How do we pull all these things together to make sense and to visualize the data that we think that we need to make better care decisions? So there always has to be, it's not about just taking the data and analyzing it. There has to be a problem or a challenge that we're trying to solve. Otherwise, we're going to get lost really fast.
Absolutely. Great answer. Thank you. So we have 3 minutes. So I'm going to ask you to leave us with advice and any other thoughts that you want to make sure the audience hears before we conclude.
Well, I'm going to say advice is a little strong, Mark, but my thoughts, my guidance for those leaders that are on the call, I think that really understanding where you want to be in the next 5 years as far as your infrastructure around analytics and your capabilities, I think that investment is going to be very huge in being able to really move the needle on our patient outcomes. And I'll even go beyond to say our community health outcomes, because patients we typically think are the ones that we're just taking care of for a period of time within our 4 walls. As a healthcare organization, we really have more. We have more to offer and we have more to give. We have to be able to take care of our community. So the integration of data is going to be critical. So it's about partnering across the community, partnering with our payers, partnering with our employers. It's going to be a lot of partnerships, I think, that make this happen.
That's a great answer. Thank you. And we'll have to have you back so we can talk about the social determinants of health, because we really didn't have a chance to do so except for a brief reference. But I want to thank you so much. I will just say that from my perspective, this is, first of all, a very exciting area. And secondly, we have made progress in the last 10 years. We've identified what some of the key areas are to measure, both in the hospital sphere and on the medical practice side. And we're starting to do it. And I think we're learning best practices over time. And I think that the policy payment piece of this is really coming into focus. Mm-hmm. We need to somehow create greater value in healthcare, improve patient outcomes while bringing down the cost curve. And this is going to be an absolutely key element in doing that. So, Ekta, thank you so much. It's been terrific.
Thanks, Mark. I really enjoyed it.
Me too. Thank you. Well, Stephen has magically reappeared, so he's here to close for us.
Yes, thank you, Ekta. Thank you, Mark. It was such a wonderful conversation, and thank you to those panelists that attendees that asked questions. This concludes this session. Please join us right back here at 3 p.m. Eastern for our final interoperability panel, our final panel that's focused on interoperability. I guarantee you will not want to miss it. It is a panel full of great characters, and they have a lot of great information to share. So thank you again to IBM for supporting the program. As a reminder, all these sessions will be available on demand. Thank you again, Ekta, Mark, and we're out of here. We'll see you guys at 3 o'clock. Take care. Bye-bye.
Thank you.